Hello, welcome to this Vaginal Health CME. I'm Dr. Malhotra. I am a NAM certified menopause provider, the program director of the Women's Health Residency Program at UBC, and the chair of the Canadian Foundation for Women's Health with SOGC. In today's educational program, I would like to define the genitourinary system syndrome of menopause, review the pathophysiology of vaginal atrophy, review the clinical presentations of GSM, or genitourinary syndrome of menopause, including the impact on quality of life, understand patient selection regarding treatment of GSM, review counseling tips regarding GSM, and understand treatment options at various stages of presentation of GSM. When we're talking about GSM, or genitourinary syndrome of menopause, we want to be inclusive of all symptoms that can present under this broad topic. This is inclusive of vaginal atrophy, which includes vaginal dryness, irritation, a change in discharge, dyspareunia, postcoital spotting, but as well lower urinary tract dysfunction, recurrent UTI, lower urinary tract symptoms inclusive of urine urgency, frequency, and dysuria. Also, sexual dysfunction, desire, or arousal disorders are important key aspects of this spectrum. The term genitourinary syndrome of menopause encompasses all of these important aspects of pelvic dysfunction. The genitourinary syndrome of menopause is, by definition, the deterioration in the structure and function of the urogenital tissues due to tissue aging, but most importantly, estrogen deficiency. This can occur at any time in a woman's lifespan. The normal physiology of vaginal tissue is a vital aspect to understanding vaginal atrophy. There are layers that include the outer elastic smooth muscular layer, the middle connective tissue layer, but most important, the inner stratified squamous epithelium. Within this layer, there's a mucus-like fluid, glycogen, bacteria, lactic acid, which is fermented from glycogen, and it has a slightly acidic pH from the lactic acid. The vaginal lining thickness is defined by the amount of estrogen within this tissue. A diagram is key to understanding this problem. On a premenopausal woman or a non-hypoestrogenic woman, we see plump tissue with a great vascular blood supply and tissue that is lubricated and hydrated. In a postmenopausal woman or a woman in a hypoestrogenic state, particularly chronically, we see a far different picture, as you can see. There is less elasticity, there is contraction and retraction of tissue, thinning, dryness, less vascular blood supply, and thinner tissue overall. The clinical presentations of vaginal atrophy include many things. Some of the symptoms you may see in your clinic that present are itching, discomfort, pain during intercourse. Unfortunately, one issue in this presentation is that patients may not inform you of what's going on. We need to work on normalizing this issue. One barrier in regards to vaginal atrophy is the underreporting by patients and under-asking by providers. One study studied such a phenomenon. It is the VIVA trial. It really consolidated the views and attitudes of patients within this demographic. 3,520 postmenopausal women globally, inclusive of a Canadian site, were used to collect demographic information regarding vaginal atrophy. Results were astounding. 45% reported experiencing vaginal symptoms. 63% of women failed to recognize vaginal atrophy as a chronic condition. 75% felt vaginal atrophy negatively impacted their life. 46% of women lacked the knowledge needed to describe and understand vaginal estrogen. 30% would consider vaginal estrogen as a treatment option. The conclusion of this study was that there is a low understanding of vaginal atrophy. That's something we as providers need to work on. A second study, the Closer survey, was also a key aspect to understanding patients' views of vaginal atrophy. What was a landmark portion of this trial was that partners were included within it. This survey was online of 1,000 married or cohab North American postmenopausal women with vaginal atrophy, but also 1,000 male partners of postmenopausal women experiencing vaginal discomfort. We don't often get the partner's view, so this was a great trial. The objective was to determine the impact of vaginal discomfort and estrogen therapy on intimacy, relationships, and women's self-esteem. The results included that 58% of women avoided intimacy due to vaginal discomfort, and 64% experienced loss of libido. 64% also experienced pain during intercourse. Regarding the male results, they believed that their partner's vaginal atrophy led to avoiding intimacy due to vaginal discomfort in 78% of cases, experiencing loss of libido in 52% of cases, and 59% reported painful sex. 30% reported stopping having intercourse altogether due to vaginal discomfort. That's very unfortunate. Continuing with the Closer survey, North American women using local estrogen to treat vaginal discomfort reported less painful intercourse 56% of the time and an improved sex life 29% of the time. Male partners reported 57% of times, but now looking forward to having intercourse once vaginal estrogen was used by their partner. That's a big and important change. The conclusion of the Closer survey was that vaginal atrophy negatively impacts relationships. However, this can be ameliorated by the use of vaginal estrogen, a key learning point. Patient selection. Within your practice, it is important to have key questions asked regarding vaginal atrophy. You want to ask, are the symptoms situational only, or are they day-to-day? Are symptoms frequent and impactful, and most importantly, what is the impact on this patient's quality of life? Whenever we talk about menopausal symptoms, quality of life should be top of mind. On your examination, do you see smooth vaginal walls and tissue? Do you see petechiae? Do you see a small introitus? These are key findings within vaginal atrophy. Regarding patient selection, focusing in on estrogen deficiency on all patients in your history and even when a patient books in. Think of your patients that are postpartum, those that are younger and suffering from premature ovarian failure and insufficiency. Consider fertility patients within this as well. Perimenopausal patients, those that are on GnRH analogs, those with cancer or autoimmune disorders, and don't forget our smokers and those on medications. Supporting clinical observation. A common problem. A menopausal epidemiology study was done. A random sample of 1,480 U.S. women aged 40 to 65 years old who were menopausal and sexually active were included within the study. 57% experienced vaginal atrophy, typical symptoms, and 55% had female sexual dysfunction. So don't forget back to our first slide where this is inclusive in GSM. Women with female sexual dysfunction, or FSD, were almost 4 times more likely to have atrophic vaginal symptoms than women without. Thus, bearing in mind when someone comes in with a sexual dysfunction complaint to your clinic, it's important to do an examination on them. Unfortunately, it hasn't been a trend long term. 59% of Canadian women have claimed their healthcare provider, in fact, never raised the subject of vaginal health, something that we definitely have room to improve on. The International Menopause Society recommends Patients may be reluctant to talk about the symptoms of GSM. We all know that. Relationship and sexual issues may be associated with vaginal discomfort, something to include in your workup and history. Vaginal and urinary symptoms respond positively to vaginal estrogen therapy. Counseling tips. Conversation is truly the key in all aspects of menopause, but particularly this. Questions that you may want to ask your patient. Have they had uncomfortable pap smears in the past? Have they had problems with intercourse? Vaginal infections, urinary tract infections, or vaginal irritation on a regular or semi-regular basis. Detailing the purpose of a vaginal lubricant to your patient. It is important to be very clear about this topic as there is a high level of misunderstanding regarding this. The purpose is to decrease friction during intercourse and smooth penetration, to prevent frequent urinary and vaginal infections, avoid daily discomfort, and to prevent bleeding secondary to atrophy. Including all of these within a counseling session is vital to the success and usage of any lubrication method. When we talk about treatment, there are many. Water and silicone lubricants can be used as needed primarily for situational discomfort like intercourse. Moisturizer containing polycarbophyl for temporary symptom relief can also be used. Tissue repair agents such as hyaluronic acid on a regular or semi-regular basis is another option. Mucoadhesive polymers that retain a large amount of water, which may be 1,000 times more than its own weight, and form a non-greasy water and light permeable film on tissue, such as Repagine, can be used on a regular basis. Vaginal estrogen is another option on a regular basis. The conversation continues. We want to determine the need for which and the best option for our patient. We want to counsel to the most effective method that the person is safe to use and most comfortable using. Review usage of methods and have follow-up with this patient. It is vital to see this patient back on a semi-regular basis. Vaginal estrogen. Vaginal estrogen is considered the gold standard in treatment. The effects are well known and include an increased vaginal blood flow and lubrication, increased elasticity, more rugosity, and clinically your patient will be very happy. It will improve their dyspareunia, it will decrease arousal disorder, improve desire, and the patient will have less secondary sexual and relationship dysfunction, something that's very challenging to treat. Vaginal estrogen is the most effective therapy for GSM. A Cochrane database review showed greater than 90% improvement or cure in dyspareunia, greater than 90% improvement or cure in vaginal dryness, a reversal in cytomorphological atrophic change and vaginal pH, durable efficacy at 12 months, an equal therapeutic efficacy with CEE cream, the estradiol ring, and micronized estradiol vaginal tablets. In summary, key learning points that I hope you take home include GSM, the genitourinary syndrome of menopause, encompasses both vaginal and urinary symptoms of menopause. GSM is a common chronic condition that can have a significant effect on a woman's quality of life. Women suffer in silence. They are reluctant to initiate a dialogue about their symptoms and are unaware that effective treatments are available. Physicians need to routinely discuss and effectively manage the symptoms of GSM in postmenopausal women. Further, treatment of GSM should be a stepwise approach considering all symptoms. Women are open to discussion and treatment with local estrogen therapy that maintains normal systemic hormonal levels. Treatment with local estrogen is effective, simple, and safe, and it can transform a woman's quality of life, including intimate relationships. Local estrogen therapy is also highly effective at preventing UTIs and treating LUTS, lower urinary tract symptoms. Progestin is not indicated when appropriate low-dose local estrogen is used, although long-term data past 1 year are lacking. Let's do some case studies. Penny, case 1. A 58-year-old woman, she's healthy, a G2-P2, and her final menstrual period was at 49. Her presenting complaint to you today is recurrent urinary tract infections. She is not currently sexually active. She is on no medications, has never had surgery, and is a non-smoker. The conversation within her appointment should include: how frequently are you being diagnosed clinically with urinary tract infections? She states every few weeks. What have you used in the past for treatment? She states she's been treated with antibiotics for each episode. Can you please tell me more as to why you are not sexually active? She states sex is not comfortable. How do you feel about vaginal estrogen? A nice open-ended question. She says she's open to the discussion if it would help with her UTIs. You complete your workup for her frequent urinary tract infections. After treating her current E. coli infection with antibiotics, you discuss the use of vaginal estrogen to treat her GSM. GSM is defined for her, and she is surprised to hear bladder health is included as part of the diagnosis. She is agreeable to the use of vaginal estrogen after you review the safety and detail the use with her. Case 2, Sheila. She is 62 years old, healthy, on no medications. She's a G3-P3, and her final menstrual period was at 50 years old. Her presentation is that she has some questions about menopause. The conversation includes that you complete a history inclusive of the following questions. Are you sexually active? Is sex comfortable? And do you desire sex? You obtain as many details as you can from open-ended questions. She states she is not having sex because she is uncomfortable and her partner asked her to come in today. Remember back to the closer study. Her discomfort during intercourse is leading to her partner no longer initiating sex because he is afraid he is hurting her. She is motivated to improve the situation. You examine her and found mild atrophic changes inclusive of mild thinning. You examine her and find mild atrophic changes inclusive of mild thinning. She has no other complaints or concerns today. You review non-hormonal treatments. You ask her to return if she does not get relief or if she has any questions, concerns, or changes in her reproductive health. An open door policy is really important in these cases. Thank you very much for attending this session.